To those of you that don't know me, my name is Donna Ostrofsky, and I'm expected to remember that. It took me a while to remember that last week. A little difficult, and it's not Italian. I work at Griffin Hospital right now, which is a very small community hospital. But I've kind of done the larger routes. I was at Yale for 25 years, in the city for a few years. And then over my family, I got retired. Somebody else makes me up that I can't refuse or have too good to give up, too good not to do. So I'm still working, but it's a very small community hospital. It doesn't affiliate with anybody, so we're still independent, kind of nice and neat in the same way. But anyway, I'm here to talk to you today about stroke prevention goes a long way. So what I'm going to do first, I'm going to throw it out to you. Every day that you come to work in the perioperative area, primarily OR, most of us go to OR. What's the biggest thing that you strive to do? Make sure that keep patients Katie, thank you. Katie and I used to work together. She stopped me with. And you froze my screen. Yeah. And it was okay. You're going to report it. Okay. It's not working. It's me. Try again. So major concern in the perioperative environment is ensuring patient safety. Becker's has outlined 6 steps to ensure OR safety and efficiency. So it begins with scheduling accuracy. It goes to appropriate patient preparation, supplying instrumentation set, clear communication, timeouts, and management of OR technology. That sounds like not a big deal, but that consumes every bit of our time for every single patient. So it's not just a one-shot deal on any given day. You're doing one case, it's got one case. How often do we just do one case? You know, minimally invasive cases have progressed to the point where we can do anywhere for 5, 6, sometimes 7 cases depending, especially if it's ophthalmology. So ORs, and they try to be, and very often are, well-led machines. They rely on several moving parts to conduct surgery safely and efficiently. All those parts must be alert, careful, and calm, and it also strives that they work together cohesively. Very often, ORs have tons of protocols. They don't always use it. Yeah, there's new recommendations, there's new standards, there's what we do versus what the standard is saying, so you try to coalesce together. But we should be, OR should be, very well-oiled machine. Ensuring patient safety, where does it begin? Does it begin in the OR? So where does it begin?
When they walk in the hospital.
Actually starts before. It starts actually when that conversation happens with the surgeon in the office saying, we need surgery. Maybe not today, but we really need surgery. That's actually where the safety pieces start. Remember that scheduling piece? So that scheduling piece starts in the physician's office. Conversations had between the physician and the patient. Agree that the surgery is needed because the surgeon has explained everything to that patient that they need to know and they understand what they have to look forward to. Then the booking happens. He goes over to the OR schedulers, wherever they may be. Ours are still in the same OR facility. Some people are in different buildings, but it doesn't matter. It's all IT. That's where it starts. Before I even get ahead of myself, it's there, but we also have to pay attention when we're looking at a patient and getting ready for any procedure. We have to pay attention to all the types of preventable medical errors that could be encountered by this patient, that we are a part of, have to hopefully try to avoid. So it's a lot on us, isn't it? And then we also have to be aware that surgical errors are unique to our environment. We're not going to find surgical errors on a med surg floor, are we? Now, what I did put on one of these slides is what the stack rules define surgical errors as. It's an unintentional preventable injury occurring in the perioperative period that is not considered a known acceptable risk of surgery and could have been avoided by following appropriate procedure-specific training protocols. It is a type, however, it's a type of medical error. But some of the things that we try to avoid are changing our bodies, misleading assessments, wrong site, wrong procedure, wrong patient errors, and we can go on and on, not just that. So we have to be aware of these surgical errors. We have to keep open to all those preventable errors. And then, what are some of the things that you do on a day-to-day basis to prevent all those errors so that patients can be safe? You already know what begins in the doctor's office. Then what happens?
Checking to make sure you have everything for your case when you're setting up.
Mm-hmm. Anything else?
Sure, I know all pre-op instructions.
Pre-op instructions. Anything else?
Consent matches what's on the schedule.
Correct. Anything else?
Consent matches.
24-hour
Patient
days.
says
Patient identification. Make sure it's right patient. That right, it goes on that consent, right? Make sure it's the right side. I think we've all known somebody that's had sometimes surgery that was either unwarranted or wrong side. And that's kind of a sensitive experience. It never happened in my family. I had my daughter in our house. The timeout wasn't done.
That's horrifying.
It was very horrible, especially when she called you up. Yeah, you know, so key aspects or elements of what we do every day kind of look like this. I don't know if you can see it all. It's a little bit faint here, which is fine. But again, it starts in the doctor's office. Day of surgery, all this happens. All the way down to number 13. I should have been worried. I actually just sat there and I was like, what does our day kind of look like? What does it look like for us when we are taking care of that one patient? Because the nice part about what we do, I think, it's a one-on-one. You know, we don't have to compete with 6, 7, 8 patients. It's us and that one patient.
Thank God.
Yeah, I totally agree. But it's kind of nice. But all of these things happen with just one patient. So like I said, it starts pre-procedure, preoperative, day of surgery, you're doing all these things. As you said, consent, patient ID, laterality, confirming the assessment, the HMP, looking at labs, confirming the NPO status, any meds taken, making sure they get the appropriate ABS. And yeah, I know that's mostly anesthesia, but we're still part of that. And in some organizations, we still get the antibiotic for that stuff. You know, we are all part of that. Equipment, that was mentioned before, making sure that we have the right equipment, the right devices, the right implants for whatever procedure we're doing. And any concerns and miscellaneous issues that we may have. Maybe we see something that either a lab that doesn't look quite right, or a behavior that's not quite right. Something, you know, and then you can dig a little bit deeper and you question it. The handoff communication is huge from pre-op. So they should have an idea about that patient before that patient rolls into the OR, don't you think? I mean, I know with traumas and stuff, we may do a 5-minute assessment, and we get pretty good at that because we really don't have much of a choice. Most of the time, they're not going to talk to us. They're hurting pretty bad, you know. So on an elective way, that handoff starts a lot. Whether we go out to the pre-op area or not, which is a deal, that really helps a lot. And any of the documentation that we send. And then this is all that happens in the NOR. And I'm sure there's some things that I missed up here. When you look at all of this, you have sign of anesthesia, appropriate proper positioning, padding, anatomical alignments. Again, making sure one more time, the equipment's in the room, does it work?
Sometimes it's a deeper dive into something that you say.
Exactly.
Because I had a situation where a patient, we have ERS protocols for IMR, and you know the patients always are asking, did you have any Gatorade, orange, or you know any kind of sports drink, you know, before you came in.
Right.
And she kept saying orange, you know, I had orange juice. I was like, I had to stop her in a second. I said, are you telling me you had like Tropicana orange juice? She goes, yeah, I did. Like, I kind of looked around like I was the exorcist, and I said, look, I didn't see her like, are you okay with that? So sometimes you just have to feel like,
Sometimes they don't even realize that.
yeah.
I worked in a facility in New York City that was very intense into sports, you know, the big time sports. And this guy is sitting there, you know, football players, microscopic next to it. But he was sitting there, and I was like, why didn't you can't go? And I have no idea who he did from. He didn't carry coke. Very busy.
You just find yourself as a nice 8 hour.
I had fish sandwich. You should just go there. I've been interviewed by anesthesia, surgery, whoever, and then I go out last person, and he gives me a little heart. And I said, when's the last time you ate or drank?
2 minutes
What was
ago.
that? He goes, I ate a fish sandwich.
What does it matter? We get all through it, right?
You know, that's my
The happiest person then asked, maybe I better fess up.
So, yeah.
Must be.
Don't you feel like the last line of defense though?
Yeah.
The first sample, and all in the middle too, absolutely. Because you just wonder, I mean, are you comfortable telling me, or do you just know that you have to fess up because this is it?
We found, we
Yeah,
found.
even the ones, I'm sorry,
We found that somebody was peers had to tell, like, we were the last stop, they're having laparoscopic surgery and.
Yeah.
yes, yes.
Oh, yeah.
And we were like, we can't.
Yeah.
do your
Right.
surgery.
I remember being, shooting a young lady, and I could see like a million piercings on both ears.
Yeah.
You know, and I had multiple piercings, so it wasn't the fact that it was multiple piercings. And I said to her, is that all the piercings that you had? She went, no, and then she started rattling them off, and I'm like, looking at her like stunned. And it was, she came, I think I had like 32 or 30 something piercings. And I was like, that's all great, but
I gotta come out.
otherwise, you're not
We have problems.
Yeah, so anyway, it's amazing what we do, and then don't forget, it continues, all of this, all your safety checks and timeouts, med errors, or preventing med errors, performing your counts, ESU safety, fire risk. All of this transcribes into post-op, and then they do their thing with pain management, fluid loss or no loss, making sure there's wound care, airway management. That's a lot, and that's per patient. I mean, when I put it together, I had a fatigue for the next effort because I wrote it all. I was like, you don't really realize that you're doing it, even though we do this every day.
And there's so much behind it.
And it's I mean, it's a lot. It's really, really a lot. I think it's a lot. So maximizing patient safety means you have to minimize the risks. It's crucial that we minimize risks, but you need to know what the risks are. So some of the risk exposure that patients have that we have to decrease. Anesthesia complications, surgical errors, we had that already in line. Some of these slides are going to be redundant because everything we do is paramount. Don't just do it once. Surgical positioning errors, post-op infections. We need to possess a clear understanding of the procedure and the equipment. Sometimes I think we all wonder women and men, because obviously we have a lot of women in our profession too, but it's amazing what we have to know and have to take care of. And again, it's a lot, and then we wonder why we're tired of it.
A lot of residents aren't trained appropriately on how to position, and they start positioning for you, and you're like, wait.
Right, see, in our facility, because it's a small community facility, the nurses kind of take the lead in that. I'm not saying that some of the physicians don't know, some. And I said all. Right, but the nurse takes the lead in that. But I know when I looked at the level of trauma center.
Right, all kind of people, you're like, I don't even know how my patient got positioned, and you want to check, especially stirrups, you're like, which I rarely have stirrups on my patient, but like, that's not even right.
I remember one time I got yelled at because I didn't put the legs up simultaneously, and I literally stood there like this, like, seriously? I mean, do you really think I'm tallest person in the world, and actually lift my 2 legs up at the same time do this? It's like, and there was nobody else in the house, so it wasn't like there was a whole lounge full of people. Everything's busy. So it wasn't, I didn't do it aggressively, but you just do it as safely as you can. But anyway, we just have to know risk factors, and it's just not minimal. And possessing that clear understanding again of the procedure and equipment, and then you're going to enable a seamless surgical experience. Now we all know about patient fall. I mean, it's not just hear about it during our health streams, mandatories. They do a lot of data collection about patient falls because it's huge. It's huge for the patient because of potential injury and the injury. It's huge for the organization because it's extending their patient care and into all of that patient. But the potential complication for us especially in operating room, that very often gets overlooked is our patient falling off the edge. That's the scariest things I can even possibly imagine. Knock on wood, wherever it is. It's never happened to me personally, but I know that, it's happened nationwide, probably internationally. And that's one thing that's, obviously not good. Most often when the patient falls off an OR table, it results in temporary non-disabling injury. There are 9.5% that sustain some type of permanent severe injury. So it's a harm to the patient, not insuring the patient. It's potential for a surgery or another surgery, depending on what happens. And then it's financial cost, not only on the patient, your insurance, and the organization. And unfortunately for all of us, we have to think that way. It's not just a one thing. So what are some of the contributing factors to a patient fall? Our OR tables have evolved. I'm not sure about you, but this is what I grew up with. And this is not new, but this is what I graduated to.
Oh, you didn't have to unscrew and pull the fracture.
Oh, yeah, we had all that, yeah. I mean, this is what it looks like today. This is not what came into Yale, the OR at Yale when I grew up there. It was, I remember standing there, all of us looking at it going, God. We're supposed to put this on and put it together and remember all the pieces, and then stick a patient on it. Almost we just look at each other like, what a miracle workers? This is like insane, but this is what it's progressed to. And why does it progress to something like this? Mostly it's because of minimally invasive procedures. What's the easiest way of getting a patient on the OR table, positioning them, quick exposure, stable exposure of the surgical area, and then getting them home? It's not going to be on this thing because you're not going to get any good exposure, especially like in a fracture, an orthopedic fracture, which is what happened. So they do things to expedite speed of surgery, which also extends to different ranges of positioning. I don't ever recall seeing a severe Trendelenburg like this in all my years until a lot of the new equipment. We always had Trendelenburg. We always had reverse Trendelenburg. But nothing close to this, thank you, robotics. It's amazing. Lateral tilt. I probably would have been, if I was still doing clinical, I would like to stand on the floor pulling the patient petrified because that would have never happened. But because of, again, changes into that designs of beds, speed of changes, expanding all the ranges of positioning, everything's changing. And not for our benefit, it's for the benefit to keep the patient safe, but to do it all. And that's, I think, the scarier part. So, what this all comes to is just prioritize the safe surgical positioning. It makes it easier for exposure, it makes it better for exposure, it doesn't make positioning easy. Doing these type of positions, like Jackson tables, Hannah table, trios, and everything else. Another contributing factor is the patient. Very often the patients are agitated when they're going under sedation, right? Stage 2. And they can have an altered consciousness. So it's not just when they're undergoing anesthesia, it's when they're also resurging, correct? And then our obese population is increasing. The obese population results in maldistribution of weight across the OR tables. Our OR tables have changed in design, but has the width of the OR table changed? Not really. What they can hold has changed. I remember the person who got a table that held 300 pounds. We were amazed. Taken out of to at least about it. Yeah, so it's like, so that part's changing, but the width stays the same. So you have to spot in all that stuff because they're large people. So again, it reduces the margin of safety for your common surgical positions because it could be just a herniorrhaphy, but because of the obesity, you're doing a whole bunch of this that hoping that patient is safely down in the position that held on to it. All of this creates potential for surgical positioning. Questions so far? Another contributing factor is us. We are considered the provider. We intended facilities just like providers, just like patients. We are part of the healthcare. So for this PowerPoint presentation, we are part of it. Not solely, but we are part of it. Often, staff are distracted, and they're really not watching it, just what they should. Concerned with documentation, we're concerned with the conversation in the corner, we're concerned with what Linda did over the weekend, she got married. You know, we're very, very, very distracted. And as, again, redundant, under sedation or awakening, patients are, or can be confused for agitated, right? Sometimes there's an assumption that other healthcare providers are securing the patient. You're not securing the patient because you're circulating, because you do have a whole bunch of this cool. You haven't delegated, you know, to someone else. I'm not saying you can't do that, but they're not gonna know. Because they're not gonna know what you do.
Even if you delegate it, you're still going to court if something gets screwed up.
Very, very correct. But the point is, you can't just assume that somebody's watching the ship.
Right.
Because you're supposed to be watching the ship.
Right.
And if you're not watching the ship, then you need to delegate it. Someone, ask that person, stand by that patient, not lose their assignment. We need to know when the anesthesia is getting ready to anesthetize. You know, because we've had H2 anesthesia, whether it's general anesthesia or not. If they're using those kind of medications, they're going through stage 2, no matter what we do. And that's the side effect. That will never ever change unless they change the way they're actually doing sedation. You know what I'm saying? So we can't be distracted. We can't be having sidebar conversations. If you do leave the room for whatever reason, you need to make sure that somebody is standing in your space next time. It's our responsibility. That's our patients. So, you know, we should be taking it all very seriously. But we get lost in all the things that we need to do. And some people, I'm sure, are documenting because there's so much to document. And although free documentation is not acceptable, I'm sure that happens. So, you know, you have to just be careful. Patients should be the first thing. And then the other part of a provider's actions or inactions is inadequate application or absence of the safety staff. And I don't know about you, but I was always taught that that patient gets on that OR table, the first thing that goes on is the safety strap. Not the arm boards, not the pillow, you're gonna get to all that. You're gonna have a blanket, but that safety strap goes on. I don't care what position they're gonna fall into. There's two kind at that point, they're on that OR table. OR table is not right. It's not inside the bed. So that safety strap has to go on. This is one of the biggest leading factors to adverse events. And we already talked about what a surgical error was, or is, an adverse event. It can be avoided and can be prevented. It's just up to us, pay attention to all those risk factors. The patient going under anesthesia alone is a risk factor. And with all the anomalies or whatever they come in their bags that they come. So patient falls. Again, preventable, they're adverse events. So they get reported most often. Our major concern, as we said, is ensuring patient safety, right? We also are ensuring awareness of risk factors that may contribute. So it's such a critical element to avoiding any type of adverse event, like a patient falling off the OR table, flying that safety. Is it the only thing? No, absolutely. But it is a bigger thing than most people think, and they can't take it. I've seen surgeons argue about having a safety strap. I don't like the buckle. The buckle's in my way. But we have ones that have on the table cover. And you're looking at something. All that education, you're worried about a buckle. I mean, come on. Yeah, I mean, it's just, you know, anesthesia. Well, we can't put it across the chest or the belt. You know, if we're putting it on correctly, space. So it's really not constraining anything, but that's a conversation. It's not just, you're not doing it. You know, I mean, that's crazy. And what's the anesthesia going to do when that patient starts moving and falling off the table? You got the head. That shoulders down.
Let's go.
It's a free fall. You know, I mean, it's all about us and whoever else is down that. Anesthesia's up in the head with that airway. So unfortunately, yes, they are part of that conversation, a very crucial part. They should know that they shouldn't just call the shots independent. And I get it with, you know, potentially infringing on your respirations and things of that nature. There is a way of doing things the protection of the patient. But often putting the safety strap or, eliminating and not using it, it goes unnoticed for a variety of reasons. So what actually are the safety straps? Technically, the medical devices used not just for surgery, but for our purposes, surgical procedures. They're made of strong, durable materials. They come in a variety of options. You can use them for full body mobilization, bariatrics, armboard straps, and even for people with sensitive and damaged skin. They can be either disposable or reusable. They come in different lengths and widths. They can accommodate patients of any size, even my size. And they can be used on sensitive or damaged skin, and some of them have different closures, hooks and loops, and can be used on tables with or without side rails. So again, there's such a variety of things that we could do. I'm from the day where you had one type of safety strap, and if you didn't do anything else, you needed a 3-inch plug. And I'm not saying that's something we should go back to, but we had to search for that 3-inch plug tape sometimes because they didn't have a lot of it. But it's not good for the patient when you're pulling on the skin. They have developed so many different types of positioning tools, safety straps, Velcro, rubber, it's amazing what's out there. I just realized about a month or so ago, they have something specific just for the Honda tip, which I find actually, and I'm because it's such a great idea, and I'm advocating for well, we don't have a hand table. No, fine, you don't have to switch them out. We have a Trios OSI.
Okay, yes, the same thing.
Exactly. But what I'm saying is, I never saw that.
Right,
And I was like, that's an idea. Because it helps you with moving the patient besides restricting the patient from moving. So, what I'm saying is, there should be no constraint. There is no reason why anybody should say we shouldn't be using a safety strap. It's not about the belt, it's not about the hooks, it's not about the width, it's not about the length, it's not about anything. We have them. If we don't, we should get them. We should get a variety, at least of lengths, widths, bariatrics, short people, PD people, it doesn't really matter. We should have that available. Not just for us that have to apply them, for those patients that rely on us. I always tell everybody when a patient comes in for surgery, sometimes they're kind of grabby and just not. And I was like, no, you're talking about a person who's walking into a hospital that most people don't want to be anything. Not about the hospital function. So, but being in a hospital, you're scared to death. They think they're all going to die. They're going in a hospital. They're never going to come out. You know all those stories. And then they meet all these people that are telling them what to do, touching them, move this, show me this, and they have no idea who anything. And they trust us. They like you. But do they come in here? Nobody wants me. No. They're scared. We get scared. We get apprehensive when it's us. Maybe it's because we know too much, but the point is, it's very scary. So they're not going to come in thinking that you're going to hurt me today. They're hoping like heck that you don't hurt them. But they want to go out the way they came in on walk-in, and they rely on all of us to provide them with safety. So what's the role and purpose of safety straps? Again, little redundancy, they're designed to secure, immobilize, and properly position. They provide safety and stabilization during surgical procedures. They facilitate access for the surgical team, meaning for the incisional area. They minimize the risk of potential harm to the patient. So what do? Their primary goal, even though it's an inanimate object, primary goal of putting it on is for the preservation of patient safety. Benefits of putting them on, again, redundant, securing and mobilizing. So there's a common theme here, properly positioned, maintaining that position, ensuring no unnecessary movements. Have we ever been in a procedure where in the middle or getting close to the critical part of the procedure, the patient decides to lighten up a little bit? Arms fall off arm board. They're just wiggling around.
Or they try to help you.
Yeah, that's what, as a joke, we say that, they're just trying to facilitate and move us along, just and you're like, what the? Now you get under those drapes, make sure that the safety strap is on, hopefully it is on, put the arms back where they belong, and make sure that it's proper. I'm not going to take off stuff, right? Sure, every surgeon would love to have that kind of in place, right? So, again, it's up to us to ensure no unnecessary movements and maintain that optimal access to the surgical site. From what we talked about in the beginning, we need to minimize the risk of those complications and provide each patient with the best chance for a successful surgical outcome. So the benefit of a safety strap is they are a silent partner. I know that sounds crazy, but in the literature, that's actually what they call it. That might be. Why should we apply them every single time? Because they meet the needs of every patient. Joint Commission, DPH, CMS tells us that we have protocols, but we have to make them suit every single patient. But with the variety of types of safety straps that are out there that we have, I think that standard can be met there at least as long as we apply them. They're purpose-built, they're durable, they're versatile, and they're strong. We guarantee by applying them that patients remain in the correct position, even if they move. I mean, if they're really moving, anesthesia's gonna, do their thing up there, and then we just have to make sure, without disturbing sterility, that everything is as it should be, as far as alignment and stuff. We need to foster that secure environment for surgical teams to work effectively, and again, that's the reason why we're putting them on. Reducing the risk of unintended complications, reducing that risk of an adverse event that happens during a surgical procedure. We need to ensure patients receive the care they deserve without compromise, and they play an integral role in patient safety and success. Again, they're like an unsung hero, without even trying to, the quiet guardians, the unsung heroes. So why don't we want to do 24/7? Every patient makes their choice. By applying them, all we need to do is choose the right step for every single patient. Again, there's a variety of types. We go through the disposable versus reusable. Know the patient's condition. You're not going to put the wrong size strap or a tiny skinny strap on a bariatric. You're not going to put a very wide strap with big buckles on a pediatric patient that is much shorter than me. That I can use in a pediatric in the size of type of procedure. You need to know the type of procedure. There are specific types of table straps for a specific procedure. Robotics. Maybe you do robotics.
No,
Good God. Feel decrepit now. It is busy. For me, it is. Different surgical tables come with different safety straps, like the fracture table. And I keep focusing on the fracture table because I think that is one of the.
It's almost one of the most dangerous.
It is. I think it is the most. I mean, I always thought when I first started that when you did neuro and you put the frames in, that was the worst thing.
Yeah, that's pretty.
It was, but I don't think they're even as bad as those fracture tables. I mean, they look like something out of some kind of.
People don't realize that the crash post is actually what holds people on bed.
They don't. And people don't realize when that's pulled, patients are like dummies. I mean, I know it sounds crazy, but they are.
And that's
They
what
can't fight themselves. They can't resist falling because they're anesthetized. Even if they're awakening, there's no connection between the brain and the body saying, I can fall. And they can't stop themselves, so they just go. Just hoping that when they go, if they go, that they just don't get really, really harmed. So the correct type of surgical table strap achieves the best possible patient outcome. Once again, ensuring patient safety. That's what we do, day in and day out for every single patient. Also, besides choosing the right steps, we have to implement best practices. Just a couple of best practices that we do when the safety gap goes, I can't even talk anymore. The safety strap goes across the patient's thighs as soon as they're transferred. How far do they go? They go up here. They go down here. Where they go?
2 inches.
That's been like, the knee interval.
It's hard, it's not.
And just remind them, when they get have you ever had a patient that has that claustrophobia or has spatial issues, doesn't like to be touched?
Yes. We found that if you let them hold the mask while they're going under anesthesia, it gives them control, and for some reason, it makes life-changing difference.
But it takes a conversation before you even get to the or get to that.
Right.
And the only reason I'm saying that is, with all the years, I can still see him to this day. He was different, and he was a big guy. He was like, he had to be like 2-something, 6-something, sitting more than 6 feet. Even laying in the bed, it was impressive how big he was. And I don't mean like an obese, just a big guy. Didn't like he touched major spatial issues, and he said he was claustrophobic. And he was explaining to him what's going to happen when it gets or take the strap on, and you can see his eyes like, and he goes, "You can't touch me. I can't do that." And I said, "How about if I stand next to you and put my arm over you?" He said, "Any of that." So anesthesia, and I guaranteed that, but I was standing right next to him. Although I'm not honest person, I would make sure that we had extra people and have, that we would be right there so we wouldn't hurt. That's the only way we done this. Because couldn't put a safety strap, couldn't touch it. And you couldn't move it. And you couldn't catch it if you got to the middle. So you just have to have that communication. What's the best thing for education? It's not about us. Yes, we want to be safe. But if we do things safely, we apply things safely, inadvertently, we will be safe. If we don't do any of that, they should be hurt. And so, and that's honestly. Also, another best practice, time is just enough to secure the patient without impairing superficial blood flow. That's to the heart. I think that makes sense. You're going to put it on, but you're not going to. So it is going to secure them, but if you do, for whatever reason, have to walk away, even if it's just over to the table there, you turn around and see that moving a little bit. You have time because that safety strategy. Go right over here. Make sure you're not that safety strategy. The time is gone. Because that patient's going to go. And again, remember, you cannot stop them. I don't care what kind of mix, general, regional, doesn't matter. They cannot. They're all somehow compromised in some way, not just physically, but mentally. They cannot stop themselves. My kids would be happy if they heard my voice coming. So safety straps should be placed, again, 2 inches above the risks of not using outweigh because they're using them. Not using them creates serious consequences for the patients and the surgeon. And that would be that. So in conclusion, patient safety in the OR is paramount. Surgical errors are unique to this environment. Preventing them requires a vigilance team effort. Everything we do takes a village. Everything we do works as a team. Without being a part of a team, it's not about us. So, they're the same thing. It's great if you want this to come to a cohesive plan that incorporates patients. Despite changes in health care, the constant concern is to ensure exceptional patient safety. Patient care must be delivered, again, safety utilizing the appropriate tools and the guidelines. But we also have to recognize that we are human. That's our biggest flaw, which we'll never get rid of, which is good, because I don't really care for robots. We are human, and it's inevitable that we are going to be just don't make it so bad that it's on the failures occur by choosing inappropriate methods of care or by poor execution of an appropriate method of care. Not using safety straps jeopardizes patient safety, compromises the surgical precision, but it's incision, and exposes patients and the surgical team to avoidable risks. Properly using securing the patient is a fundamental aspect of responsible surgical practice. Always prioritize the safety. Safety straps. There are so many out there now. It's not what I had to deal with 50 years ago when there was very often everything was generally anesthesia. So I had some near misses a lot. And back then they did go unrecorded because It wasn't like a negligible thing, it was just like, nothing happened, which is fine, have to report it. It's different thing, and that's not a bad thing. Sometimes reporting things makes us more aware, and then we get those protocols in. Everybody out. Maybe obviously the surgeon, absolutely anesthesiologist. He doesn't really think of it. Thank you for coming.